morning, good afternoon, good evening, wherever you are. And thank you for attending the second day of our workshop on our report on optimization. So just a couple of housekeeping things first. We were asked about attendance certificates, and they are being prepared and will be sent out by the ICRP Secretariat after the workshop. And PDFs also of the presentations will be available, and they will be available eventually on the website. And also both days are being recorded, and so recordings of the whole workshop will also be available later. So the first day of our workshop really described the different aspects contributing to optimization. So today we want to look at more the sort of optimization and get some views from around the world of how things might work. So think about problems in implementing optimization, particularly in countries which have perhaps less facilities than some of us who've been involved in writing the report. So I want to start off with Mika Kotusniemi again, who's going to talk about building optimization into routine practice. So thinking about putting things into your departments. So I'll hand over to Mika.
Thank you, Colin, for this kind introduction. I will share my screen and just check that you can see what I see.
Yeah, that's fine.
Great. So again, good morning and afternoon to everyone. I come from Helsinki University Hospital, and I will speak about building optimization into routine practice, as Colin said. Yesterday, I briefly talked about image quality, and today the subject is somewhat more broad, and it actually extends up to the leadership level, where we certainly need a commitment for human resources, infrastructures, financial resources, and methodologies, meaning the tools we use and processes in place. So it's a fairly wide area which we should cover when we think about the successful optimization in the practical environment. There are many factors which affect the whole imaging quality. Yesterday, I referred to this image about image quality issues, where we talked about the different roles of medical physicists in technological point of view, the radiographer handling the workflow issues of image capture and presentation, and finally the image interpretation of radiologists. So what is apparent already from this image is that we are dealing with a comprehensive process of imaging, which needs many fields of expertise in order to make this optimization and overall quality successful concept. So the whole process and whole imaging chain must be evaluated. And this also emphasizes the need for multi-professional collaboration between radiographers, radiologists, and medical physicists, so that everyone can bring their own best knowledge into play when we define the practical implementation of how the optimization is done in the clinical facilities. So these were the main components when we are aiming to improve our optimization. And basically, what we were trying to do also in the report is to define a clear pathways of professional issues, methodology, meaning the tools we have, and processes, so that regardless of our stage as an organization, and maybe financial resources and technical infrastructures and staffing, we have clear steps for improvement of our own optimization. So As mentioned, we should have a clear roles between radiographers, radiologists, and medical physicists, where traditionally those roles have been quite rigid, and we have a hierarchy in the organization, which should be, however, flexible in order to improve our optimization practices in real life. So what we hope to do when we want to improve our optimization is to advance into versatile joint tasks and responsibilities between professions, and finally stitch them as closely together as possible into multi-professional teams working towards the common goal of improving the image quality and balance with dose. Yesterday, I talked about image quality, which mostly relates here to the methodological component, where traditionally we have been measuring on a technical level image quality with technical phantoms. In dose aspects, we have the basic dose performance testing. But if we think about optimization, we should elevate from the traditional quality assurance point of view and try to go to more comprehensive testing of both dose and image quality parameters. And that's why we need new methods, and that's why we need to build that bridge from traditional technical parameters towards the clinically relevant parameters. So we hope to end up in the advanced level to use task-related metrics, which give us much more leverage to manage clinical image quality in balance with dose. And then the processes which relate to also to our documentation and how we handle data flow in radiological organizations. In the current fully digitalized environment, we have increasing data and increasing access to that data. So we should be able to utilize that also for optimization practices and quality assurance. So as we have described in the report draft, we have different methods for example, dose audits to utilize dose monitoring systems organization-wide to utilize big data to capture not only the typical operation of the organization, but also the outliers and deviations. So we try to build from isolated site-specific activities and sporadic documentation towards systems which are applied across the whole organization. And within each of these components, professionals use tools or methods and processes. The levels of performance we can achieve obviously can vary in different organizations. And that's why we hope to light a clear steps in the document how we could advance specifically in these three fronts of advancement in optimization. This is an example which was already shown by Colin about the DRL or dose-related optimization point of view, where in the basic level we have radiologists, radiographers, and medical physicists, which have fairly separate roles and independent working habits. And when we establish diagnostic reference levels, which were described by David yesterday, it involves more movement from this basic level to the intermediate level, where we already involve optimization teams between radiographer, radiologist, and physicist. And when we have established that team, we can together compare those survey results with the diagnostic reference levels, review them, and use our common expertise to optimize protocols for any modality or all modalities we have. And then in the advanced level, the whole optimization team is involved in regular review of clinical protocols for all modalities. So in the advanced part, I would emphasize systematic practices. They are not just short sprints of quality done for audit or something like that, but they are more like a continual practice and continual improvements. This is an example from our hospital, how we have chosen a specific target of those audits and also image quality subjective evaluation targets for regular cycle between years. So we have head and local indication, which here was perfusion. Last year, now we have a chest and a cardiac as a specific target. Next year, we will concentrate on abdomen and also trauma. These are obviously not the only targets we are monitoring for dose and image quality, but we try to put in the focus specific areas between each year. So when we have a dose monitoring system, we obviously have the full front of examinations evaluated, but we focus a special attention for also subjective image quality evaluation to certain indications and targets. So as we saw already from the general process, for example, in projection radiography, we need many kinds of expertise to reach successful optimization. And when we think about this multi-professionality and collaboration, radiologist is obviously concerned about the indication-specific clinical image quality, which we can also describe by traditional numbers of sensitivity and specificity. Radiographers handle the imaging equipment and working methods, and mostly touch the exam workflow and patient safety, take care of that. And what medical physicists bring along is the knowledge about the underlying physics and techniques which we use in imaging, meaning the interplay of imaging parameters ending up as a result to resolution, contrast, noise, and dose descriptors. So we are between the quality assurance and dosimetry and try to build from that towards optimization. And when we work together, we hope that this is how we really implement optimization successfully in practice. And for example, when we have evaluated some recent AI-based or deep learning-based image reconstruction, for example, in certain CT scanners, it's important to be open-minded and comprehensive also regarding a specific indication. It's just not about the primary diagnostics. We also have to think about the differential diagnostics and incidental findings, which matter as well, and they can be fairly complicated issues, for example, with a new deep learning-based diagnostic tools that we have seen. So there's always devil in the detail when we go further to the intricacies of optimization in certain areas or examinations. So operation of the X-ray equipment is dependent on high levels of knowledge and skills for all the professionals who are dealing with these imaging exams. And when we think about imaging settings, they should be agreed in optimization by members of multi-professional team. And they should also be documented so that when we change an imaging protocol, we should have a clear track record of what we have actually changed and why and how. So we should have also a trace of the optimization process and changes we made. And all members of the team must give their own part and also support that knowledge with training and experience. And if we think about the training and education, which we will hear more later, I'd just like to address, it should be updated regularly as our techniques are also updating. So when we acquire new systems, the user training is an important part of commissioning of a new device. And when we think about the practical optimization, I would say that one of the key parts is when we commission, take into use a new equipment and systems. So when you purchase a system, it's not just a system. What you should think about is you have purchased the whole functionality and quality with it. So require also the optimized protocols. And this should be given enough time in the commissioning phase and user training to really set the parameters right from the beginning when you have the vendor expertise present at the site. Maybe a small practical issue, but quite important. And when we think about the process and qualifiers for successful optimization, we should think of that as a continual practice. When we take into use a new equipment in commissioning, we should do that systematically also in the future. So we have ongoing, forward-looking and iterative process where we can learn and make continuous improvements. For example, in medical physicist field, when we measure quality parameters and try to use them in optimization, we have both quantitative and certain qualitative evaluations. Also, our process should be systematic and carefully structured so that we can communicate what we do and all the relevant aspects in the chain of diagnostics are taken into account. And as mentioned at the beginning, it really requires commitment on all levels of the organization to give adequate procedures and resources. Okay, optimization is not a minimization of those, and that balance we have already been discussing. Now we can roughly look at the two levels of optimization where we regularly review every aspect of the imaging process. And first of all, we should look at the design and construction of the equipment and the installations, and that spans the whole life cycle of radiological equipment, as also described by David yesterday. And then, of course, the day-to-day working procedures performed by staff, which brings very strongly the multi-professionality into picture. We will succeed in this only if we have properly trained staff, because we are in a highly technical area of medicine. And obviously, when we think about the other prerequisite of successful optimization, we need comprehensive quality assurance program to really verify that we have the full potential of our equipment in use in a technical level and also in the application level. And there is ongoing monitoring to review and analyze the performance. And this should give feedback into continual improvement of protocols. So this is a practical example of a situation where we are commissioning a new CT scanner a few years ago, and we can also reflect the report which described how we set the basic parameters and then adjust indication-specific parameters to maximize image quality per unit dose. It can involve, for example, spectral optimization, setting the proper KV levels for contrast-enhanced protocols using automatic tube voltage selection options, and then adjust patient-specific parameters, typically AEC or automatic tube current modulation in CT example, for individual exams for adequate diagnostic image quality. And what is important, especially when you have a larger organization with many different scanners and maybe many different vendors, is to harmonize protocols. And obviously it can be much harder when we have different vendors and different models of scanners in order to achieve consistent image quality throughout the organization. what is shown actually in this image is scanner protocols in the scanner console, which are then, according to feedback from radiologists, modified so that we really have the harmonized and consistent image quality. So we have here, out of the picture, radiologist, which has her notes there, and we have also the protocol guidelines, which give systematic settings, which are common to all examinations to this specific new scanner. So we can do this manually as shown in this picture, or we can use our dose monitoring system, which have expanded or can be expanded into protocol management system. So we can even handle our CT scanners protocols online from the monitoring system. But there are many options to do this, but it's important to do this so that we have successful optimization in practice. Much of this is actually delivering information between different professions. So we have a radiologist, mostly within the area of image quality considerations, clinical image quality, radiographer dealing with the workflow, medical physicist, as mentioned, handling the quality aspects and technical and physical aspects of dose and image quality. And then we have the service engineers. When we think about this multi-professional collaboration, there is a lot of exchange of information between these roles and professions. We should be active in this communication. So communication is very important. We should give enough attention and time to that in order to receive feedback on image quality from radiologists, both to radiographer and medical physicists, who can then provide their own expertise to optimize technical adjustments from physicists, and workflow optimization and patient safety issues from radiographers. Also, the exchange of information from radiographer to service regarding malfunctions and deviations should be reflected with the prompt actions for functional status and service reporting from the service side, as also to medical physicists regarding conformance evaluations and technical optimization. So there's a lot of communication which should be fluent between these roles, and it should be somehow written in the quality assurance program and also the policies and leadership of the organization when we think about the optimization in practice. There are certain main directions in improving our methods, which are common to any kind of optimization or quality advancements which we can imagine. We have traditionally measured quality on average. And now when we think about the need to be more consistent and harmonized in our imaging protocols and image quality, we should reduce that variability. So we should drive to more consistent quality, and that also give us more possibilities to see weak signals in our image quality data or dose data. So we also should then use proper parameters which are reflecting the optimization. So that's why we are trying to be more clinically oriented in our image quality parameters, because if we can measure them consistently, we have much more effective possibilities to improve our optimization. So measure relevant parameters and aim to consistency of quality in those parameters. One of the examples I showed yesterday is regarding image quality is to use anthropomorphic phantoms, physical phantoms, or calculation, or you can also use those to aim closer to clinical cases and have relevant image quality in measure. But we also obviously use those anthropomorphic phantoms for dosimetry. This is an example of 5-year-old pediatric phantom which are also used in the noise simulation yesterday, where we use MOSFET detectors to retrieve point organ doses. So if you have these human-like geometric phantoms, they are more versatile and useful in a clinical terms. So you can use them directly in your scanners and maybe get a more relevant outcome when setting your protocols at the first time, and also evaluating how a certain protocol changes may affect image quality and dose. Of course, the limitation with these physical anthropomorphic phantoms is that the full range of possible morphologies and sizes of patients, these usually just represent a certain patient model, but it's a good starting point. Another example how to approach in optimization a more clinically relevant level is to extend your diagnostic reference levels, which are traditionally given per anatomical range, and supplement these with indication-specific diagnostic reference levels. So you can be more specific within certain examinations where you are in your own dose audits also. So for example, high resolution CT volume CT scan of the chest, it has much more low diagnostic reference levels as compared to ordinary chest CT scan. Also, when we think about the implementing optimization in practice, when we think about different levels and methods to reach clinically relevant parameters, we can think about the decision to use a certain dose parameters, like here in CT. Traditionally, we have looked at the DRLs regarding CTDI-vol and DLP, which are modality-specific dose units in CT. In the future, we aim to be more relevant also with the dose aspects to go to patient size-specific global and local dose units, SSDE, to anthropomorphic organ dose determinations, and finally to patient-specific doses and effective dose estimates. There we can use our own Monte Carlo codes or deep learning methods to do this. And of course, those monitoring systems have included already these models into them. So we can retrieve that for wide scale monitoring of the organization. And this should lead to more effective optimization and also give possibilities for dose registry systems and further radiation safety research in the long run. So when we think about the continuum of different blocks of our operation, from quality assurance to optimization, and between optimization and justification, these core radiation protection components, we can think about the gradual unification of those when we utilize enhanced methods of optimization. So we can think of patient-specific parameters with clinical focus and wide-scale online data access and monitoring as in touching points or glue points between quality assurance and optimization, where evolved parameters and monitoring methods give more effective patient-specific optimization with clinical relevance. And the same thing with justification. If we have integrated automated referral guidelines in the form of clinical decision support, pair that with harmonized imaging parameters and protocol rules, we can help automated guidance and protocoling, which connect optimization and justification more closely together. So we can think of this advancement of optimization in clinical practice also gluing together our core parts of radiological protection. Of course, it's not so easy. We are humans, and in our organizations, we have obviously the formal policy, but in addition to that, under the surface, we have informal practices and cultures, beliefs, values, and attitudes. So that's why we have such a strong need for more extensive and comprehensive changes for our organization, and we should think about the cultural changes. This requires leadership, commitment, and activity from that side also. So we cannot do just mechanical changes and hope that it would somehow proliferate into cultural changes by itself. So changes are sometimes tricky, but we should be able to do that because in order to make improvements by planning and doing, we should also monitor and take care of the outcome so that it will be an effective one. So the importance of continual improvement is obvious. And finally, I would just like to address some common roadblocks or steps on the road, how we can actually put together important issues of successful optimization. So we need to have a proper infrastructure and technical resources. And in the very basic level of quality, it means that we have a availability of phantoms and test objects and measurement devices, which will then be used in the QA quality assurance program to give prerequisites for optimization, and then implement those audits together with the diagnostic reference levels to do one of the core parts of optimization regarding dose. And then pair that with regular image quality evaluation. And if we think about the certain key systems that we can use to improve optimization, certainly those monitoring systems give organization-wide online view to our dose data, including also the outliers and deviations which there might be. But in order to do that successfully, we need to have a proper human and financial and technical resources, definite roles in staff, and keep our personnel trained in multi-professional level, and also have the processing and documentation so that we can communicate actually what we do in our optimization. And finally, I would like to address that our digitalized environment is very vulnerable, and we should think about the data safety and security also. So with this, I would like to thank you for your attention and acknowledge the contribution from the members of this task group. Thank you.
Thank you very much, Mika. That was a very comprehensive look into how we move forward. Now moving on to looking at the education and training, and Kimberly Applegate, who's an interventional radiologist, and she's chair of our ICRP committee. So she's going to talk about education and training.
Thank you very much, Colin. I hope you can all hear me. And I'm so pleased to add on to what's already been presented so well that this should be just a solidification of much of what Mika has already presented, and yesterday what Dr. Dina Husseini, a radiologist, has also said in her team building discussion. So I'm going to talk about chapter 6 in the document and the importance of education and training. I have no conflict of interest. So I wanted to start with the main points and how they relate to and embed language about education and training. Some of this was already mentioned by Mika, so this will be solidification, so to speak. One of the key points, or main points, I should say, says optimization will only occur if all staff are properly trained in their roles and responsibilities so that we can do our job well and safely. Another key point says that feedback into continual development of protocols and regular review of every aspect of the imaging process is key to the successful achievement of optimization. And this is what I would term a culture of learning. And I have a image on the left-hand side of the slide explaining or demonstrating what safety culture is. So staying away from punitive cultures and moving toward blame-free learning culture. So we have a just and a blame-free culture of learning. And that means that we identify if errors occur, they're not because of people deliberately doing things wrong, but in fact, they're doing things because they haven't either adequate training or because they're put into situations where there aren't enough staffing or there aren't adequate tools to be successful. So the third point on this slide is professionalism. And this is really talking about thinking about internalization of learning and the values of the facility where they work. And this can be learned from professional societies, from the organization and learning provided by the organization or academic programs. And a recognition, as Dr. Husseini said, and also Mika just demonstrated, with respect for unique sets of skills to improve imaging performance and addressing deficiencies. And then also having necessary expertise so that we can all evaluate how we're doing. We must not just say, well, we have our policies, that's good enough. No, we must look at how we're doing. Two further main points relating to education and training include that optimization will only occur if all staff are properly trained. And we've mentioned that a couple of times now. And finally, that we live in a very complex environment in medicine in general, and specifically with our equipment. It's like driving our car today. Our cars are very highly digital. They're very complex, so we can't just fix them ourselves anymore. Our equipment is very complex. The software is very complex. So every time there is something added on to it, we must require from our managers and from the vendors that we have that training. And it may be iterative training where the vendor application specialists come back multiple times in that contract to give us the training we need to be using all of the software and all of the aspects of the modality, like CAT scanning, to be as good as to provide as good of a use of the equipment as we can for all of our patients. So now moving on to the chapter, and there are 9 key points in the chapter to talk about how we can deal with the complexity of the digital environment. And one of the things that we talk about is we must invest in an adequate staffing level when we're thinking about the equipment life cycle. And David Sutton talked about this yesterday. Well, we have to have trained healthcare staff and a commitment to their continuous professional development. I mean, we can't just buy a piece of equipment and not have enough staff or not have staff adequately trained. So this is a key point. Another one is that we talk about knowledge, skills, and competencies, or more recently termed attitudes and behaviors, which all can be measured, and this should start at the undergraduate level and continue throughout our radiological protection community careers. So they don't stop at any one time, but they must be continuous, and there must be an investment in this KSCs or KSAs that are supported by employers, audited by appropriate authorities, be they the professional societies or the regulators, depending on where you work, and focused for each professional group. So it shouldn't just be the same for everybody, it should be focused. And then try to establish national standard credentialing for the individual professional group, and accreditation for the curriculum and feedback from the students. All of these points are essential. I wanted to mention that there are a couple of tables. One is for the healthcare professional roles and responsibility, and Dr. Husseini mentioned this yesterday, and this is helpful to look at for describing each person's roles and the importance of sharing information and learning in that blame-free environment. Sometimes this is very informal, and being on a listserv, an email group, or sharing at a national meeting, very, very helpful. And the medical physicist has a crucial role in this education and training. So they need to be recognized as a professional in medicine and the RP community, and have adequate resources to perform this role. Vendors also have a crucial role in optimization training. And we point out that there are many free web-based resources that are increasingly available, sometimes on the professional society websites, sometimes at academic institutions, and they allow for us to provide it any time of day or night and on demand. So that doesn't always have to be a person at your local place being the expert. And then one figure in the document is figure 6.2, and it provides the forms and levels of learning that are identified in what's called Bloom's taxonomy, which is well recognized in the education sphere. And we provide a brief description of the processes which would apply in the context of optimization. We also provide an Annex F, which gives a table of examples for the application in optimization, so that you can look at that. So this figure provides the words, the language that are used for applying educational measurement. And when you're developing continuous development learning, you use words like remembering at the basic level, all the way up to understanding, applying, analyzing, evaluating, and creating. And each step of the way is a higher level of thinking skill. So it's being able to move up that table of learning and thinking skill. I wanted to show that digital imaging has really moved us forward in many ways. It's expensive, but it's also efficient. And it's also provided better care for our patients. So it allows us to do better dose tracking and modeling. And Mika pointed this out, that we can use Monte Carlo modeling and AI and machine learning. And sometimes we can do better by combining those two for CT organ segmentation for the individual patient. So this is moving forward very rapidly. We improve optimization and image quality. We improve workflow efficiency. Think about how fast we can do radiography now compared to before we had it. And then radiomics is a new field, and it can predict outcomes, for example, in chest CT for lung cancer. And it can better detect pancreatic cancer. And this is a paper that came out, there was a paper that came out this year using CT scanning compared to the expert abdominal radiologist. However, with the complexity of medicine today, we need higher skill levels and KSCs. We need integration and we need communication systems, as has been pointed out by several people already. And we need continuous review of the whole system involving equipment, protocols, and processes to ensure safe and optimal care. So I leave you with just a few references that touch on education and training. We've had a prior publication, 113, from 2009, and especially the tables that provide the specific professionals in radiological protection and medicine, tables 3.1 and 3.2. We also have another task group looking at the ethics for radiological protection in medicine, diagnosis, and therapy, which touch on how to look at values when evidence doesn't exist. And this can be very useful too to look at. It should be out for public consultation by early next year. And then Zhenya Vasileva may be speaking next about some of the IAEA collaborative work. And then the National Academy of Sciences in the United States has published a call for broad-based radiation science education in medical schools. Finally, there are free modules on the Image Wisely website that look at the education strategies from basic values to performance behaviors that can be measured. And with that, I will stop here and we'll move on to the next speaker. Thank you very much.
Thank you, Kimberly. I think that's given a good overall view of training and education. As Kimberly mentioned, Zhenya Vasileva, who has helped us with quite a few of these ICRP reports. She's the radiation protection specialist from the IAEA, so she can give a better indication of the sort of how optimization varies around the world, and say something about the support the IAEA gives, which may sort of respond to some of the questions that we've been having. Thank you, Zhenya.
Thank you very much, Colin. Hope you can hear me and see my presentation.
Yes, everything's fine.
Thank you. Okay, I'm here with my two shoes as the member of the task group, but also, and I'll speak today mostly from the perspective of the IAEA. This presentation was prepared jointly by me and my colleague from the Dosimetry and Medical Radiation Physics section, Olivera Sira-Bielak, and you'll see the resources from both Radiation Protection of Patients unit that I represent and the Medical Physics section. You know that the statutory function of the IAEA is to accelerate the use of nuclear applications and to establish safety standards and provides for the application of these standards. And this is based on the ANSCIR studies, publications on sources and effects, and the ICRP recommendations for protection. In the area, this development of these standards go through a formal process of consultation with the member states and the relevant professional bodies, and thus they reflect the international consensus, not just expert opinion, but international consensus. And that's why the process of developing of standards is long. It takes few years after the recommendations of the ICRP has been issued. The current international BSS was published in the General Safety Requirements Part 3 of the agency in 2014 by 8 international organizations, and the Implementation Safety Guide for Medical Uses of Ionizing Radiation was published in 2018 in cooperation with 4 jointly sponsored by 4 organizations and in cooperation with the international professional bodies. We all know that following the definition of the optimization in the ICRP publication 103, the international BSS specifies that the application of the optimization principle to the medical exposure of patients and to the volunteers as part of program by medical research requires a special approach. And this is defined as the management of the radiation dose to the patient commensurate with the medical purpose, and especially for the diagnostic and interventional radiology, keeping the exposure to the minimum necessary to achieve the required diagnostic and interventional objective, because too low or too much radiation will be equally bad because the diagnostic images will be of low quality. So this principle, implementation of this in practice requires several components very well described by previous speakers and very comprehensively in the new publication of the ICP. And this includes components such as equipment design and software calibration, QA and QC dosimetry and diagnostic reference levels, and the operational aspects such as protocol, techniques, parameters, and of course, periodic reviews, audits. And responsibilities are also shared between the key health professionals, but also some others such as vendors, service engineers, licensees, regulatory and health authority and professional bodies, especially for setting regulation, setting DRLs at national level. The last two have very critical role. For the implementation, the guiding document for the IEA is the bone call for action issued jointly with WHO in 2012. And also this application is, and all the actions are in very close collaboration with many international and local organizations and professional bodies. And this includes providing guidance, training, technical assistance, knowledge exchange, building awareness. From the IEA work and from the IEA collaboration with many different parties, with many, in fact, all 175 member states, I will try to very briefly summarize what are the common issues in implementation of optimization. As we know from the many studies the IEA performed in the last 15 years, that the large variations in the patient doses continue to be in place despite all the actions to improve optimization. For example, this is an old study of CT practice in pediatric radiology. This was the largest study in 40 countries, showing 22-fold variations of doses from the CT of children for the same protocol. A more recent study of protocols in doses in abdominal area also showed variations, especially the lack of reduced dose protocols for example, urinary stone CT examinations due to the unoptimized protocols, but also very frequent use of multi-phase imaging. And the most recent study during the COVID of practice in 62 city facilities in 34 countries also demonstrated high variations in practice of use of chest CT and resulted patient doses. What are the challenges with optimization? Among the obvious different access to dose reduction technology in different parts of the world and lack of access to those data in digital format in many less developed countries. There are also many other linked to human resources, such as knowledge and skills of health professionals, often linked to lack of good professional qualification or lack of training on practical radiation protection aspects, lack of access, full lack of access to qualified medical physicists in medical imaging in some countries, or very limited number of such professionals. Safety culture and teamwork also lacking, and also enforcement through national legislation that is linked to the various weak collaboration between regulatory bodies, health authorities, and professional bodies at national level in some countries. And also this also describes the lack of national DRLs and patient dose monitoring programs, inappropriate in many cases quality management, quality assurance program, often limited only to few simple technical quality control checks of equipment, and a lack of operational procedures and optimization protocols that is also linked to many of the previously identified problems. Just on the enforcement through the regulation, because the IAEA role is to ensure that the international basic safety standards are properly implemented in the member states. We recently analyzed the legislation of 24 countries in Europe and Central Asia that are a part of the technical cooperation region of Europe, and found the major issue to be the access to medical physicists in diagnostic and interventional radiology. That is lacking in the requirements in most of the countries. You see that only in 42% of the countries this was required in the legislation. And this is linked to the establishment of quality assurance program, comprehensive quality assurance program, and also is lack of DRLs in diagnostic and interventional radiology. What I am saying is not the lack in practice, it's the lack in the legislation itself. Also, formal education of medical radiation technologists exist in only 40% of the countries. Requirements on radiation protection training and competence are in many cases general, not specific to medical exposure. And we also found, because half of the countries were EU member states, the other part non-EU member states, that much better enforcement exists in the EU member states due to the binding European directive. So the role of the legislation should not be neglected, because this is the way to put at least the framework for the optimization. Then, of course, there are many more actions needed. And in 2016, we, for example, analyzed the situation with diagnostic reference levels and those monitoring for optimization of protection in medical imaging in big technical meetings. And the main points identified, the main components that require development were identified to be human resources and responsibilities linked to increase the number of recognition of medical physicists, raise awareness and responsibilities. Secondly, training, basic and continuous training, proper mentoring and oversight. The third, safety culture and quality culture that also requires work and emphasizing the team culture. Regulations, these should be required by the legislation whenever lacking. And funding, of course, that can facilitate quality of data collection. And few words on the IS support for improving optimization from both radiation protection of patient unit and the dosimetry and medical radiation physics section of the IE. The first is providing guidance. You can see a number of freely available publications on different aspects of introducing new technologies, results of coordinated research projects, and the most recent publications on dental radiology. Tomorrow we are going to have a webinar on this publication, and the newest one on patient radiation exposure monitoring in medical imaging, that it's not yet published but is available in the preprint repository of the IAEA, and we believe this publication will further help the process of implementing exposure monitoring systems. Free training material provided for trainers in 15 training packages. The most recent on radiation safety culture building, handbook for trainers, all available for free download. E-learning for self-learning, available through the learning management system of the IAEA in English, Spanish, and Russian. Here you can see those related to radiation, to diagnostic radiology. Free webinars, up to date, 75 have been broadcasted. Technical cooperation events, trainings, visits, fellowships. And all this is available through the public website of the IAEA. From the dosimetry and medical radiation physics section, considering the very important role of medical physicists for optimization, You can find also many relevant resources. The objective of this section is to contribute to the advancement in dosimetry and medical physics and provide support to the IA member states in this area with the final aim to support patient care. Access to medical physics services and appropriate dosimetry are paramount prerequisites for the implementation of the optimization principles, and this defines the important role of this section of the IA. Here you can see different resources, activities of the section in the direction of harmonization of radiation dosimetry, publication of guidelines on QA and QC, publication of guidelines for harmonization of education, training, and professional development of medical physicists, as well as certification, provision of dosimetry services and postal dosimetry audit, the last being important for radiotherapy, supporting the development of clinical medical physics services in low and middle income countries in the framework of the technical cooperation program, and supporting the establishment and strengthening of national educational program in medical physics, including audit and certification aspects. And here you can see those publications available on the dosimetry in diagnostic radiology, the dosimetry code of practice, international code of practice, and a series of publications related to computed tomography, mammography, and new under development. Also providing calibration services and the network of SSDL laboratories. Clinical medical radiation physics and quality assurance is support to this field is also important. Here you can see a series of publications, several of them related to digital radiology, digital imaging, worldwide implementation of digital imaging in radiology, or quality assurance in digital mammography. The most recent one on implementation of remote and automated quality control program for radiography and mammography. Clinical audit is a key element for the development effective system for managing quality in healthcare, and DIA is offering these audits and of course provide methodology for this, including comprehensive clinical audits in diagnostic radiology practices. And here you can see the document tool for quality, for quality audits as a tool for quality improvement. They are also ongoing and previous coordinated research activities. For example, the one that has been finalized is evaluation and optimization of pediatric imaging, and the new ongoing one is on the evaluation of the dosimetry needs and update of code of practice for dosimetry in diagnostic radiology. So the IA is committed to support the medical physics profession with the aim of ensuring safety, quality, and effectiveness of radiation medicine. And to do so, the IA has been supporting all the elements that compose the profession. And you can see here these elements. You can find the relevant resources related to the medical physics, especially medical physics in diagnostic radiology from the Human Health Campus of the IA. Another very useful resource for medical physicists and optimization. Here you can see different publications and also e-learnings. We believe that the new ISRP publication on optimization and the actions from the IA and partnering organizations, we will hear from some of them now, will help address the current issues and improve quality and safety in medical imaging. With this, I want to thank you for the attention.
Well, thank you, Genia, for setting out all the publications and other sources that are available. We're having a slight change of order now, as Boris Bujacic from the University of Zagreb who's presenting on part of Eurosafe, has a family matter he needs to attend to. So we'll go straight to him. So if you want to share screen, Boris.
Thank you very much, Colin, and thank you for allowing me to speak a little earlier. So in next few minutes, I would present, do you see my slides?
Yes, we can see them.
I would present the view of Eurosafe Imaging, which is, as you know, initiative of European Society of Radiology that is quite active and has done a lot of a lot of projects over the last years. Now, one of the things regarding the optimization activities is that we have so-called Eurosafe Imaging STARS program. It was updated and relaunched in January 2022. This STARS program requires applicants to meet high standards in optimization and includes criteria such as specific protocols available for all equipment types, use of national or local diagnostic reference levels, also an operational multidisciplinary optimization team, and a radiation protection educational program. We had this STARS program already for several years. Many radiology departments in Europe and also elsewhere have applied. For STARS, we have updated it and relaunched it in order to make it more appropriate and we think a little better. We have a special working group that deals on this, and we think that this is quite successful and enhances optimization and justification, in particular European radiology department. Also, clinical DRL's working group is producing a statement on local DRLs, as well as a practical DRLs made easy booklet. And this builds up on the work of the successful EUCLID project. This is European study on clinical diagnostic reference levels for X-ray in medical imaging. Regarding the analysis of patient doses, the Eurosafe Imaging Joint Working Group on dosimetry and dose management have carried out a survey on the use of DMS across Europe, and a publication of the results is currently being prepared. It's practically finalized. I would just like to remind you, many of you probably know about relevant Eurosafe imaging publications, and some of you were co-authors there. In March 2022, a publication was published about notifications and alerts in patient doses for medical imaging. In July 21, about dosimetric quantities and effective dose in medical imaging, a summary for medical doctors. In March 21, cumulative effective dose from recurrent CT examinations in Europe, proposal for clinical guidance based on an ESR Eurosafe imaging survey. In September 2020, publication about radiation dose management systems, requirements and recommendations for users from the ESR Eurosafe Imaging Initiative, and in March 2020, harmonization of imaging dosimetry in clinical practice, practical approaches and guidance from Eurosafe Imaging Initiative. These are the most important publications and the most recent one. Regarding the evaluation of image quality, the strategies for image quality of the future working group is currently producing a paper entitled Appropriate Image Quality and its Determination as a Tool for Optimizing Medical Imaging in Terms of Radiation Protection. It's headed by Christoph Heschen, medical physicist from Germany, but we are also involving our US partners in drafting this paper. Regarding the education and training of clinical staff in optimization methods, Eurosafe organized series of imaging webinars in 2022, we had a series of 10, for the first time, CME accredited webinars, which was organized in collaboration with European School of Radiology, which is the main instrument of European Society of Radiology for Education on a European level, and we were able to get CME accredited courses, and those webinars focused on computerized tomography and on interventional radiology, 5 on CT and 5 on interventional radiology. They were quite well attended. They attracted almost in total 2,500 live viewers from 103 different countries. So we had around 250 per each webinar attendees. They were organized in each webinar. There was radiologist, radiographer, and medical physicists as lecturers, and those webinars primarily covered dose reduction strategies, optimization of clinical protocols, and use of diagnostic reference levels for the different anatomical areas. And we are now preparing a new series of 8 educational webinars on radiation protection, again in different fields. Also, Eurosafe Imaging organizes scientific sessions at every European Congress of Radiology. Next will be from March 1 to 5, 2023 in Vienna. And we are covering a range of radiation protection topics, including optimization. Finally, just to mention some European projects that are currently active, that are also covering mostly or partly, or at least partly optimization. We have EU Just CT project, which aims to improve justification of computed tomography in Europe through coordinated action. So it's not on optimization, but primarily on justification of and auditing of CT referrals in 7 European countries: Finland, Denmark, Belgium, Estonia, Greece, Hungary, and Slovenia. It's roughly in the half of it. It lasts 3 years, and we will be able, hopefully, to present results relatively soon. EU REST is completely new project which aims to provide an analysis of workforce availability, education, and training needs in EU member states to ensure quality and safety aspects of medical applications involving ionizing radiation in the European Union. Then there is MEDIRAD, European Project on Implication of Medical Low-Dose Radiation Exposure, that you are probably familiar with. Also, Euramed Rock and Roll will yield a strategic research agenda in the field of medical applications of ionizing radiation and related radiation protection. Euramed is European Alliance for Medical Radiation Protection Research. And then iViolin is also quite new project which aims to satisfy clearly identified need to optimize and harmonize oncological imaging procedures in Europe and ensure their broad adoption. So this is in short what Eurosafe Imaging and DSR are doing in this regard. Thank you very much for your attention.
Thank you, Boris. We'll go on. I think we can see that this sort of doing joint projects and sharing information is going to be a way that we can drive these things forward. So, Emily, am I right that you're using a pre-recorded presentation?
No, I will just speak to you today, okay, since I'm able to be with you. So I will take the opportunity to speak live, if that's okay.
Yeah, no, that's good.
Great. So my name is Emily van Deventer, and I'm the head of the Radiation and Health Unit at the World Health Organization. And in terms of this ICRP TG108 report, we very much welcome this report because it provides practical guidance on optimization of radiological protection in digital radiography, in fluoroscopy, and in computed tomography. And as the agency within the United Nations system with specific mandate on public health, WHO's objective is the attainment by all peoples of the highest possible level of health. So in this context here today, WHO was pleased to contribute to the development of this report as a member of the ICRP Task Group 108, which performed its work successfully during the COVID-19 pandemic. And this was really very much under the instrumental leadership of its chair, Colin Martin. My colleague, Dr. Maria Perez, who is now retired, was the WHO representative. Now, just to give you a little bit of background, ICRP has been in official relations with WHO since 1956. And in January 2021, the WHO Executive Board reviewed this bilateral collaboration and approved a new triennial work plan until the end of 2023. And this plan aims to advance the implementation of the International Radiation Basic Safety Standards and contribute to the achievement of the United Nations Sustainable Development Goals. And in particular for us, the one that's important is SDG 3, which is to ensure healthy lives and promote well-being for all at all ages. So this new report, the TG108, that's presented in this workshop, very much links the concept of optimization with the notion of quality of care and good medical practice. And this is fully consistent, of course, with the goals of our collaboration. Now, WHO is working to mobilize the health sector towards safer use of radiation in medicine. And we do that through our global initiative on radiation safety in healthcare settings and by supporting the member states in their implementation of the priority actions that have been identified 10 years ago in what we call the Bonn Call for Action, which is jointly promoted by IAEA and WHO. So today, the title of this session is Putting Optimization into Practice. And so how does this topic fit practically with the work of WHO? Well, as we all know, the COVID-19 pandemic has highlighted the importance of ensuring accessible, affordable, and high-quality health services. And this, of course, includes medical imaging. And so since the beginning of the pandemic, WHO has been working to develop different types of evidence-based guidance, and in particular, one on the use of medical imaging in COVID-19. This was published in as early as June 2020, so early on in the pandemic, and was updated just a few months ago. WHO also worked to ensure access to medical devices for COVID-19. And in this context, we published technical specifications for the procurement of radiological imaging equipment and devices. But not to dwell on COVID-19 work, we also have looked at other health outcomes. And in 2021, WHO updated its guidelines on screening for tuberculosis, including the use of chest imaging and artificial intelligence in adults. And these were expanded this year with guidelines for pediatric TB. And in all these, of course, optimization is an important aspect. Now, currently, WHO is implementing a project on optimization in interventional cardiology and the establishment of diagnostic reference levels for interventional cardiology in children in Latin American and Caribbean countries, and is also working to enhance access to medical imaging in African countries. The importance of optimization has also been emphasized in the context of ethics in radiation protection, and this has been done in a recent publication of a WHO policy brief regarding ethics in medical imaging. So how does this report fit with the mandate of WHO? Well, the ultimate goal that we have is to attain the highest benefit with the least possible risk to both patients and also health workers, but also to enhance access to quality and safety in radiation medicine towards the achievement of one of our priorities, which is universal health coverage. And this new ICRP report can serve as a tool to achieve just that. So as you've heard from Mika earlier this afternoon, patient safety is also of paramount importance. And so in this context, the TG108 will also be relevant to support the implementation of the new WHO Global Patient Safety Action Plan for the decade 2021 to 2030. So you can see that there's a lot of ways that we can use this report, but we look forward to continue and expand this collaboration with ICRP by disseminating this TG108 report in the health sector. And this is hopefully joining efforts with the other relevant partners in the field of radiation protection in medicine, including the colleagues that we've heard today from IAEA and professional societies such as ISR, ISRT, IOMP, who are being present in this webinar. So with this, I would conclude these views from WHO. Thank you very much.
Well, thank you very much, Emily. I think this collaboration between the different countries and the international organization is going to be key if we're going to achieve the optimization. I'm going to, we had put a question and answer session, but as we're running behind, we'll just continue with the presentations. So Charlotte, could you put up Kwan Lung's presentation? Thank you.
My name is Kwan Tong Ng. I'm the chair of the AsiaSafe. This is the brief feedback from AsiaSafe on the ICRP TG108 report. The AsiaSafe objective is an initiative by the AOSR, the Asian Oceania Society of Radiology, to establish radiation safety culture and ensuring the appropriate use of radiation in medicine. And we have the website, and one of them is on the regulation and codes on radiation protection in the Asian Oceania countries. You can refer to that. It was proposed in 2017 by me, and then in July 2021, officially launched by the AOSR. It was autonomous originally, but after July 2021, it's part of the Quality Safety Standards Committee of the AOSR, and then we are involved in IAEA, ICRP, and ISRQA, and the website is asiasafe.org. This is the TG108 report that some of our members have browsed through and commented on. The stratification of optimization from basic, intermediate, advanced is good for a region from low to high resource, and also low resource within a high income country. And the steps are important. It's good to spell out for those who are new to optimization, those with rapid turnover staff or junior staff or too heavy workload that they have no time to consider collimation optimal. They just let the automatic post-processing, cropping to do the trick to save the day. However, it's important to emphasize collimation and optimal exposure. And image reject rate is important, is needed, as well as the repeat rate. Often this has been neglected in digital radiography. And most departments don't have in-house medical physicists, and they outsource to a third party, a qualified medical physicist. They come periodically or even once a year, and that's not ideal. Radiology physician like radiologists, oncologists, nuclear medicine physician, they need to take ownership of this optimization protection and lead the process, and then include and guide the non-radiology physician to do those same. Also, one commented that the PITS digital radiology should be addressed specifically as children are not little adults. What is the AOSR position or AsiaSafe? And here are some of our recommendations. Image quality is king, is the most important. We need to learn how to accept what is acceptable. So the balance between image quality and dose. And also the allied professions should start being more collaborative and improve communication with the non-radiology colleagues that is aimed to improve patient care and outcome. All stakeholders should be involved in radiation protection, not just radiology-related staff and physicists. So that will include engineers, nurses, referring physicians, and so on. And this particular report from the TG108 should be widely marketed or distributed to management, health ministries, as without regulations or framework, it's difficult to get hospital administration to allocate resources for something that is not immediately tangible to income generation. So that is our brief position, what our recommendations are on this particular TG108 report. Thank you very much.
Thank you, Kwan. Yeah, I think the point of getting things into regulations is something we've got to stress for all countries around the world. Now, Monica Bernardo, is going to report on behalf of Latin Safe. I think you're speaking live. Is that correct, Monica?
Are you seeing the presentation?
Yes, everything's okay.
Thank you very much for the opportunity to participate in this important workshop. My name is Monica Oliveira Bernardo, and I'm representing Latin Safe. So I'm going to talk with you from Latin Safe. I'm a radiologist. I'm a member of Latin Safe executive member and leader of radiological protection group of Latin Safe and SLAD. And I'm coordinator of the Brazilian College of Radiology Committee. So the projects from Latin Safe and Brazilian College of Radiology focus on radiation protection of the patient, professional training in clinical practice, and communication benefits, risk, and dialogue following bone correction initiative. So we are very grateful. Thank you very much for this document. We are going to follow this for the orientation, and I think we most are in level G and level C. We are very heterogeneous in Latin America, but we are progressing in some projects that I'm going to show. And I think it's important to engage the radiologists because the legislation are focused on the radiologists to represent the Department of Radiology. Sorry. So Latin Safe and Brazilian College of Radiology actions are some of the projects we are doing. Those reference level based on clinical indication to adult patients in Brazil. We based it on the Dr. Graciano Paulo project in Europe. And then we extended to Brazil, to Latin American pediatric those reference levels. And now we are in this process of giving feedback of the protocols, optimization, and doing a training education to the stakeholders and doing a guideline. And we are, thank you very much for all the institutions that participate on this. And would like to thank especially to Kimberly and Genia that helps us in this methodology also. So in the clinical indication, those reference level in Brazil that we are doing, We have engaged 13 institutions, 8 states, and 9 protocols based on clinical education, and almost 500 exams. So we engaged multi-professional team in all these states, and we are analyzing equipment, protocols, and quality self-evaluation. And we are planning with optimization workshop. We have done some with the help of Professor Manu Dipkara from General Hospital of Massachusetts. And we are doing our preliminary studies in publication process. We did a data collection website for Brazil and extended for Latin America about radiology, general radiology, tomography, and mammography. And each one of these has a clinical indication, like for head, we have trauma and ischemia and so on. So we have equipment collect data for each clinical indication, also data from the patient, gender, age, height, weight, and some equipment information, and also the dose. We extended to Latin America with the help of the association SLAP, that's South America, Latin America Radiology Pediatric. And so we engaged about 10 countries, and we are analyzing the data for a soon publication. We also are doing online course. So Dr. Marta, that's our president of Latin SAE. We planned 4 models. We have already done this first one model about radiation protection, engaging all the committee of Latin SAE. And this one was to improve skills to multi-professional staff about radiation protection for patients and optimization, and those in CT and radiological exams. And we have professors, important professors for all the world, and a multi-professional team engaging medical physicists, radiologists, and radiographers. And we'd like to thank very much Professor Kimberly for helping out this process. So that's all. Thank you very much for participating in this, and we really are looking forward to apply and help your help in Latin American optimization. Thank you.
Thank you, Monica. It's good to get a sort of view from all around the world. So we'll finish off now with Michael Kawoya, who's a professor of radiology from Kampala in Uganda.
This talk focuses on optimization of radiological protection in digital radiology, an African perspective. And the speaker is Michael Kawoya, Kampala, Uganda, Chairman, AfroSafe South. The objective is to discuss challenges and solutions to digital imaging optimization for the African continent. There are challenges which are related to purchasing of machines. There is often lack of adherence to procurement policies. Many times there are no equipment specifications prior to purchase. Cheap or second-hand equipment is purchased due to low resources. No after-sales service. Solution: formulate and adhere to the procurement policy. Formulate rigorous specifications. Ensure efficient after-sales service. There are challenges related to artifacts in digital radiography. Artifacts may arise from human error, usually from excessive workload, but there are also machine-related artifacts due to faulty equipment. Solution: upscale workforce, formulate standard operating procedures, conduct user training, then cultivate a culture of QA and QC. Challenges related to teaching and learning. The curricula may not include digital radiography. There are few teachers with experience in digital radiography. There's insufficient machines for hands-on training, and there are also few CME opportunities. Solution: update the curricula, train the trainers, avail hands-on equipment, and conduct more regular CMEs. Is related to applications training. Applications training is not always done for all new digital equipment which is purchased. Reasons: some of this is second-hand equipment. The applications training is not specified by the buyer or by the facility. Applications training specialists is not always available since the vendors are from abroad in many cases. Solution: specify applications training at the time of procurement. Ensure adequate applications training for all users and retrain all new users and even users who have already been trained in the applications of the equipment. Justification related challenges. The radiographers are not usually empowered to reject unjustified examinations. In many facilities, there are no clinical imaging guidelines. There is insufficient clinical information on the request forms in many cases, and there is insufficient dialogue between the referrer and the radiographer. Solution: train and empower the radiographer to reject unjustified examinations, avail clinical imaging guidelines, provide adequate clinical information, and enhance dialogue among the users. Challenges related to the radiographic technique. There may be inadequate patient instructions. At times there is suboptimal patient positioning, suboptimal machine settings, and there are no DRLs to guide exposure factors. Solution: formulate and apply SOPs for the radiographic technique, formulate and apply DRLs. Challenges related to audit, QA, and QC. Audit, QA, and QC are not routine in many centers. In many centers, there is no keeping of doors, accidents, incidents, serious adverse effects. Solution: cultivate a culture of routine audit, QA, and QC. Cultivate a culture of proper record keeping. In summary, digital radiography optimization is largely the responsibility of the radiographer, and it should focus at the entire cycle from equipment purchase to image acquisition.
Thank you, Michael. So we've now got about 20 minutes to discuss things. We've had quite a few different topics raised in the question and answer. I mean, one of the problems is the point that was raised yesterday that medical physicists aren't available in many centers, so radiographers have to take the responsibility. We haven't really addressed that in our report, but I mean, I think we'll need to think about that, and I think it will be involved in the move from level D in our system to level C. I don't know what others' view on that, but I don't see there's any way we're going to quickly get medical physicists into all the places that we want to get them. It's going to be a sort of timeline that we will eventually aim for.
Colin, can I comment on this?
Yeah.
Zenia.
I didn't notice your hand up.
Yeah, thank you. I want to comment because very often when I visit some of the countries, especially discussing with regulators, I hear this argument. We don't have medical physicists, that's why we don't include in the legislation the need of having medical physicists in diagnostic radiology. I fully agree with the comment of Lorenzo. I think he made this comment that this lack of medical physicists should not be an excuse to replace their role. Each member of the team has the role. So we should try and through different, of course, channels, and the legislation should be one of the channels of having this framework set for involving medical physicists. Of course, the lack of education, the lack of such specialists cannot be quickly solved, but we should not use an argument we don't have them. That's why we will replace by radiographers. No, radiographers have their role. Medical physicists have their specific role. And my experience shows that when lack of medical physicists exists in a whole country, nothing happens in the dose monitoring program, in the optimization. It's very, very slow process. And in order to have a progress, there should be a plan how to address this issue. And I think DIA also try to help in this process. Thank you.
Yeah, thank you. But I mean, I agree entirely. And I think level C in our diagram has to include a medical physicist, but the preliminary stage, level D, has to be the move towards that. Kwan, can you comment on this? Because Asia, it's one of the areas where I think there are quite a few countries where the radiographers try to take on this role.
Yeah, Colin, the situation in Asia is diverse, and diagnostic medical physicists majority of physicists are therapy physicists. So the radiographers have stepped in. Many of them have advanced to master or PhD level. So this is called role expansion, so expanded to the role of medical physicists. Now, this is just a stopgap measure to most people. They really can't replace the rigorous scientific training of the medical physicists. The best way to overcome this is really to start building up resources, capacity building, starting postgraduate programs to train medical physicists in the country or in the neighboring countries. So that will take a long time, but nonetheless, we still have to start. In Asia, quite a number of countries started, but sustainability is also another question. To get sufficient students, the backing from the government or the regulators is quite a challenge. Now, another quite interesting tendency or the trend, some of there are lots of therapy medical physicists, some of them sort of retrain themselves, so they sort of helped out in the diagnostic, so they are another training in diagnostic to help out and to sort of cover up the work, and that is quite a good solution. It may not be ideal, but that is a current status in many countries in Asia.
Okay, thank you, Kwan. Kimberly, do you want
just to add on to both of Zhenya and Kwan, 75% of members of the AAPM are therapy physicists. So it's definitely heavily weighted to that need. However, without medical physicists, we would not have all of the many advances in diagnostic imaging that we have had. It's not just about dose, it's about the applications that have come forward in the last 3 decades that include CT angiography, dual energy CT, and photon counting. I mean, think about all of the incredible advances that have been made in imaging and digital. So this is what we're looking at, and we have to keep all of those things in mind when we're thinking about it. And then a further comment that I think some of the physicists may want to answer is about image quality. There are more than just subjective. The way to start addressing image quality is what we've described with having the team talk about it. There has to be agreement, and there has to be decisions made about the team. And if people say they don't have time, then assign one radiologist. And this is what many places do now because we're all so busy. But one radiologist who they consider their person to address the protocols, any minimal amount of image quality they need for the task. But further, there are measurable things to do. If you need you need to see a certain structure, then that's your starting point. See that structure. So for a head CT for hydrocephalus, you can have a lot of image noise, right? That should be a specific protocol in children because that's a very common referral indication. But if you need more than that, you have a different protocol. You have a higher dose protocol. So there's an example of some things that you can do, and there are many publications about these things. So thank you.
Well, thanks, Kim. I know. I mean, there's such a broad spectrum of things that we ought to be contributing to. But Dave, you had your hand up briefly. Did you want to?
No, I was just saying that we have had a question about image quality, but we'll come on to that. I'll go through some of the questions that we've had when we finish this discussion about radiographers.
Does anyone else want to say anything about that, Michael?
Yes, I just want to say that my country is one of those countries with very few medical physicists, and most of them are in therapy, in radiotherapy. So there are very few for diagnostic, if just a handful. But I would say that countries like my country should be encouraged to step up that training of medical physicists, to step up their training, and that this training should be in modules such that they can complete a module and then that they can use those knowledge and attitudes to conduct a specific task. So a module at a time until after some time they have other modules, but beginning with a more needed modules. That way, they'll not be away from the country for a long time when studying, and then they can apply whatever module has been learned already. But we need to step up and scale up the training of medical physicists, especially for diagnostic.
Are there people within your country who could put together those modules, or should that come from collaboration with the IAEA or perhaps other groups from around the world?
I think that these modules should be not just for my country, but and so everybody would have to contribute. But as long as we decide that this is going to be a modular training, and building up until one has, and then starting with the modules which are needed most, at least for this ICRP version, then I think that would be the way to go. But that doesn't mean that we don't equip the radiographers with some basic skills which help them to cope, at least to record doses and stuff like that. But that's my feeling. Training should go on, but should be in a modular fashion.
Yes.
Okay,
so
over to you.
We can do that in the meantime. Kwan, you had your hand up. Was there that? Did you want to contribute, or is it just that you've still got your hand up from before?
No, not anyway. What Michael suggested is a very good initiative. I think IAEA have tried to have this modular training, but however, we really need a strong support of the regulator and also the radiology community. I've involved in both therapy and diagnostic. Somehow the radiation oncologists, they are much more united, much more supportive. They know that without the physicists in therapy, they just can't treat the patients. However, in diagnostics, so we can get by without physicists for decades. So we lack the kind of impetus or the strong push, as what Kimberly has gives good suggestions and justification. The different bodies, organization need to press further to get this done, else we are falling further and further behind.
Okay. Well, just let Jenny sort of finish off, and then we'll go to Dave to go through the question and answers that have been asked.
Thank you, Colin. I wanted to just join Kwon in what he said, that we need both legislation and also proactive work of the professionals. For the medical physics education, I just wanted to mention, for those who don't know, that the ICTP is running in Trieste in Italy, is running an international master program on medical physics that is sponsored through the IEA as well. So it's mostly for less developed countries. It's 2 years master program, master after master. And of course, the IEA offers guidance, especially on modular training, on education and training and clinical training of qualified medical physicists for diagnostic radiology as well. So you can have a look at the IEA website.
Thank you, Jenny. Dave, you want to go through the questions?
Well, yes, as there are quite a few, a whole lot have just come in during the Q&A session, but there is a theme, so I'll just put this out to the panel and see what people will think. Theme around people being pushed for time and having reduced access to equipment, finding it very difficult to justify non-clinical time in X-ray departments. And saying, so consequently, being able to do optimization studies is really, really very difficult. And they're saying, how do you think we should bring forward optimization in this current climate? Which is, it's really about resource and limited time, which is a theme with the lack of radiographers as well. Anybody like to put an answer into that?
I mean, I think we've perhaps got to get departments to set, I mean, got to get departments to recognize that it is an issue, because a lot of the time it's not going to have big consequences, but say with CT scanners and interventional equipment, as things get more complex, if people don't understand how to do things, and they often don't get the full picture of how their equipment is working unless they have actually carried out measurements to assess that. And so it could have serious consequences, particularly when new equipment comes into play. Mika, I think you've got your hand up.
Yes, thank you, Colin and David. It's a good thing to bring up. Maybe as I see it, it has been a problem also in our country, but the role of medical physicists has been pivotal in solving that. So it's, I think it's about the national legislation, which has partly supported our leverage to bring up the importance of optimization and invested time for that. Another thing is that it's not just a quality or optimization issue, it's a safety issue, which gives more weight to the whole concept of optimization. And as medical physicists, maybe we have been able to more strongly justify the invested time based on the safety aspect and legislative aspect of optimization.
So perhaps that's something we need to keep stressing, is the safety aspect when we get new, well, the more complex equipment installed in our hospital.
Kwan, have you got your hand up? Kwan, are you?
Yes, I just, oh, sorry.
Sorry, I don't know whether Kwan, have you got your hand up or not? Whoever was speaking just now, do you want to carry on?
I just thought in my country, what we are doing is to get students interested in some of these as their projects, because then they have a target, and that target can be achieved. They want to pass the exams. The problem with that is that quite often that work is not translated into clinical practice because it's been done by a student, but at least the information is there. Thank you.
Yes, I mean, I think both Dave and I, and I'm sure Mika and others have found that getting students involved in these projects has taken things forward. But I think the person who's supervising them then has to be responsible for ensuring that the benefits that have accrued from the work that's been done are taken forward and are incorporated. And I think that that's really one of their duties. Otherwise, when I did a survey of trying to find out who did recorded patient dose surveys and things around the world a few years ago, and I found that quite a few were carried out by universities, but they had no input then into the sort of optimization process, which was one thing that started me thinking along these lines.
So no clinical foot on the ground. Have we got time for another couple of quick ones, Colin, or not?
Yeah.
Okay, so another theme is around radiologist involvement, and I guess I'm going to ask this to the radiologists sitting around the table. One point someone's made is that radiologists insist only on high quality images regardless of patient dose due to the overall benefit of the procedure and examinations. And somebody else has made the comment that radiologists are only interested in something new like CT, but they can't be involved in anything else. So it's about culture in radiology. And I wondered if I could address this to maybe Monica and Kimberly. How to increase the involvement of radiologists in this type of effort.
I think we need to engage the radiologists, the clinical practice, showing the importance of the patient. So this legislation should put this in in evidence. In South America, we don't have this seated in the legislation, but it's not something that we need to show. So to engage the Brazilian College of Radiology and Latin Safe focus on the radiologist also, not only on all the professionals. And if the radiologists know that he is going to be important in those patients, I think is could help. Kimberly?
Well, I wanted to ask Michael Kawuya to comment because he's a radiologist.
Sorry, I didn't realize that.
I just
okay. Thank you. One of the things I've done in my department, I've instructed the radiographers who are doing CT scans that any CT scan on a child, regardless of the indication, they have to ring up a radiologist to see whether it's really justified. And whether anything else could be done instead of that, either MRI or plain film, or just don't do any imaging at all. And so I think the radiologists are still the main gatekeepers when it comes to optimization. And so I think that they should have their foot on the ground regarding those issues which are important. And they should have standard operating procedures and things pinned up as to what should be done in the protection of patients. So they should see themselves as the leaders because of the training behind them. And then the thing about quality, it's important that even as we mentor our juniors, we emphasize that, yes, quality is important, but then if a film has enough information to make a diagnosis, let's not insist on, a very excellent image. We just have to have what is good enough to see what we want to see. Over to you.
I'm going to probably pass because we're out of time, but I think if patients spoke to them on a regular and they got feedback from them, like I do in pediatric radiology, they would feel differently.
Have we got time for one more question, Colin?
Very quick question. Dave, was the one last very quick question?
One last question, yes. It's really aimed at Mika, who has obviously stimulated people to think about objective rather than subjective questions. It's how do I get away from subjective to more objective assessment of image quality? What's the first step?
So the first step may involve use of geometric phantoms to move one step closer to clinically relevant level of target which we are imaging instead of a technical phantom. As a more general answer, based on the yesterday's talk, we can use several methods involving also model observers, which will more or less add a layer of clinical task to the traditional technical image quality evaluation. And by combining those, we can really go to the level of model observer and mimic how the lesions are observed by radiologists and start to look them objectively and quantitatively. So model observers, anthropomorphic phantoms, I would concentrate on those.
And of course, no one's got the time to do anthropomorphic phantom studies in the lab because they're so busy.
Hopefully the model observer studies, eventually they'll be incorporated into software, into the equipment, and they'll be done more automatically, or they'll require less effort from the setting things up.
Yes, and actually what we do already now is to use model observers in our regular quality assurance in CT. So with a basic phantom, you can do already that, if you will.
Thank you, Mika. I think we're 4 minutes over time, so we need to wind up. Can I remind everybody that the ICRP website is open to take comments on our report up until the end of tomorrow. So if you can put in your comments, and then we'll try and address everything that we, well, everything that we can do anyway. And we'll think about some of the things that have, the points that have been raised today. So thank you to all the participants, and thank you for very useful talks. And we'll look at the website tomorrow and see what we've got in. Thank you.